Hello, everyone, and welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for this webinar. Our presenters today are Jordana Bernard and Tim Wright from InTouch Health. Jordana Bernard has 20 plus years of progressive leadership in the telemedicine industry. Jordana currently serves as the Director, Policy and Public Affairs at InTouch Health, a leading global telehealth services provider. In this role, Jordana executes strategies for key telehealth advocacy and policy initiatives. Prior to joining InTouch Health, Jordana served as Chief Program Officer for the American Telemedicine Association, overseeing strategic objectives to advance the telehealth industry in education, accreditation, practice guideline development, and alliances with professional societies, governmental agencies, payers, and industry. Jordana received a BS in Biomedical Engineering from Boston University and an MBA from Marymount University. Tim Wright has over 20 years of healthcare industry experience in operations, marketing, strategy, and new product development. Tim was a member of the original founding team at InTouch Health and has played many roles over the evolution of the company. He currently serves as Chief Strategy Officer. Prior to joining InTouch, he worked as an operations general manager for what is now HCR ManorCare. He also held positions in marketing, corporate strategy, and new product development at ManorCare and at Marriott International. Tim received an MBA from the Darden School, University of Virginia, and a BA from the University of Washington. We will begin the webinar shortly, but first, a few notices. You have all been auto-muted, but if not, please make sure to mute yourself. During the webinar, we will be able to enter questions in the questions widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or you run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website and sent to registrants. This webinar presentation should last about 60 minutes, including time for questions and answers. And now I'd like to turn it over to our presenters.
Thanks, Scott, and thank all of you for joining us today. Before we begin, I'd like to just say a few words on behalf of the entire InTouch Health family, recognizing these are truly unprecedented times. We're all working from home. We're, worried about our families and our friends, and we recognize that many of you are providers and from provider organizations. We're deeply grateful for your service. And we acknowledge that many of you are under tremendous stress, focused on caring for your communities, your patients, and your own families, and are actively preparing for what may be coming. So we wish you all well. Our thoughts and prayers are with everyone in the healthcare setting. And at one level, having a discussion about healthcare reimbursement and regulatory matters may feel a little inappropriate. However, we know, and probably because you're on this call, all of us know that telemedicine is a critical component to the effective management of COVID-19 and the resulting healthcare crisis. Telemedicine will enable the worried well to stay safely at home, will deliver treatments more effectively to those in need, will allow us to leverage providers who are not or perhaps cannot be present. And finally, telemedicine allows us to preserve critical healthcare resources for the most sick and help save lives. We're all in this together, and in that light, adoption of telehealth is critical. And to the extent that provider reimbursement will help accelerate adoption, we must pursue it as quickly as possible. And from this point of view, we're providing this update. Jordana has done an excellent job of keeping up to date with the daily changes on the policy front, and we look forward to sharing what we know with you. So today we'll first review a few key federal actions around expanding access to reimbursement for telehealth. We're going to walk through what's happened on the policy side with respect to COVID-19. Then we'll review in some detail current reimbursement opportunities. And in that context, we'll go into some very specific examples so that we make sure that you understand what opportunities are there. We'll cover a couple of last things and then save time for questions. We're going to move quickly through this. We've got a lot of material to cover, so we'll jump right in. So Jordana, why don't you start us off? And from a high level, can you set the stage for what's been changing at the federal level and what else might be in the works?
Absolutely. Rachel, do I have control of the screen? I'm just trying to advance to the next slide at this point. Just give me 1 second here. There we go. Okay, great. Well, you bet, Tim. The telehealth policy changes that we've seen evolve over the past couple of weeks have been historic. At the end of January, we saw the HHS Secretary declare the coronavirus a public health emergency. Then in early March, we saw Congress pass H.R. 6074, the original supplemental appropriations package that was then signed into law. And the law included a provision that gave the HHS Secretary the authority to waive certain long-standing restrictions on coverage and reimbursement of telehealth services, and this is in the Medicare program. Then a week later, the president declared the national emergency that invoked Section 1135 of the Social Security Act, and this also gave HHS additional powers to modify requirements and grant regulatory relief to protect the public from the crisis. This also included relief of certain barriers to telehealth. Then we saw HHS implement the telehealth waiver that removed the broad restrictions in Medicare fee-for-service under H.R. 6074. Then Congress passed the second stimulus package with another telehealth provision that was signed into law on March the 18th. And the list goes on with a steady stream of regulatory changes that have been coming out from CMS, from FDA, and other federal agencies almost daily. And the efforts here are all about expanding access to telehealth during the coronavirus emergency to give providers tools to bring a wider range of healthcare services to where it's needed, and also to clear the way for Medicare beneficiaries to stay home, receive care without having to travel to a medical facility, which helps to reduce the risk of exposure and community spread of the virus. And so in terms of what else may be in the works, the third stimulus package is set to pass any moment now. I think the final package will likely include more Medicare telehealth provisions, perhaps taking a provision or two from the Connect for Health Act, again, trying to remove more barriers to further expand the healthcare workforce using telehealth to battle the outbreak and keep people as much as possible at home. We also may see some broadband expansion coming soon. All in all, I think we're going to continue to see other changes around the use of telehealth and other communication technology-based services that will activate virtual care to the fullest extent possible as our nation deals with the escalating COVID-19 crisis.
So that's a great overview. And for clarity, I guess, Jordana, we're talking about federal actions. There's obviously a lot going on at the state level as well, but we can't keep tabs on all of that. So can you remind us where we were before the crisis, for those of you, those on the webinar that maybe aren't quite as familiar, in terms of Medicare fee-for-service reimbursement? What are the categories of reimbursement and how have they changed recently?
Absolutely. Well, let's start by talking about these different categories that CMS uses to describe remote services, because each of these categories has their own set of rules for reimbursement. The first category is referred to as Medicare telehealth. And for this category, Medicare views this type of service as a substitution for in-person care. So the telehealth visit must be a real-time, two-way audio-video encounter between a provider and a patient who is present. Reimbursement for Medicare telehealth services are the services that are defined by Section 1834M in the telehealth law. The next category, virtual check-ins. These are patient-initiated, very brief visits by an established patient by video, phone, or store and forward technologies. And the intent of a virtual check-in is just to have a quick touch base by the beneficiary with their provider to see if an in-person office visit can be avoided. In order for this encounter to be billed separately, these services cannot be related to another E&M service provided within the previous 7 days, nor leading to an E&M visit within the next 24 hours or soonest available appointment. But these services are billable by healthcare practitioners who normally furnish E&M services. Then there are e-visits, which are non-face-to-face visits, also patient-initiated by established patients, and these are done through an online patient portal. These services are billable by physicians and other qualified healthcare professionals as well. And then there are provider-to-provider visits. These are the interprofessional consultations by physicians and qualified healthcare professionals that also are billable for phone visits, video, or EHR-related visits. And then lastly, there's remote patient monitoring, which is a non-face-to-face service that CMS pays a professional fee, and also CMS pays for the technical components of remote patient monitoring as well. These virtual check-ins, the e-visits, the provider-to-provider consults, and RPM are not considered to be telehealth by Medicare. So therefore, these services are not subject to the reimbursement limitations that are defined in the telehealth law. But again, each category has its own set of rules and requirements for billing. Tim?
I thought you were going to advance to the next slide.
Sorry,
there.
my bad. You are right.
So,
thank you.
Sorry.
So yes, let's talk about what we mean by the 1834M and the telehealth law. So historically, prior to the COVID crisis, reimbursement for Medicare telehealth services have been restricted with just a few exceptions, like for telestroke. So they've been restricted to when a beneficiary is receiving a service in a designated rural area, which has in the past required the enrollee to leave their home to go to a clinic, a hospital, or other type of medical facility or originating site for the service. It also requires the service to be provided by one of the types of clinicians that are on the list of approved practitioners. It also requires the service itself to be on a specified list of approved Medicare telehealth services. And when each of these conditions, these 5 conditions for payment are met, then Medicare would pay the professional fee as well as an originating site facility fee. But again, these rules for reimbursement are the rules that apply just to the first category, and that's Medicare telehealth. So now, during the COVID crisis, here's what's changed. Effective March the 6th, so for services that have been delivered retro to March the 6th and through the duration of the emergency, CMS will reimburse providers for Medicare telehealth visits, and this is to all beneficiaries across the nation, including services that are provided into the home. So this means the rural, geographic, and originating site restrictions have been removed. Regarding providers, there's no change to the list of practitioner types who can be reimbursed for Medicare telehealth services. As far as the list of services, there's about 100 plus services on the list, and that list also did not change. However, the waiver clarified that reimbursement will be made for both COVID-19 and non-COVID-19 routine healthcare services provided through telehealth. It's important to know that although the new telehealth legislation, the COVID legislation, limited reimbursement for services to established patients only, HHS announced it will not enforce the established patient relationship requirement. So the door is open for telehealth to be delivered to both new and established patients during the crisis. Regarding the modality, there was no change here as well. A Medicare telehealth visit must still use interactive audio-video technologies. These are synchronous visits. However, there is a caveat here as well. And this is that the HHS Office of Civil Rights announced it will exercise enforcement discretion and waive penalties for HIPAA violations against providers that serve patients in good faith through everyday consumer-grade technologies such as FaceTime or Skype during the emergency. In terms of payment rates, since Medicare considers telehealth to be a substitute for in-person care, these types of visits are paid at the same rate as a regular in-person visit. When it comes to billing for the originating site facility fee, during the crisis, only originating sites that were approved prior to the crisis will receive payment or can bill and receive payment for the facility fee. So in other words, only medical facilities that are located in rural areas, with the exception of originating sites for end-stage renal disease. I also want to mention that just yesterday, CMS announced changes to the Medicare enrollment process. In order to expedite enrollment of providers to support the national emergency, they've now created hotlines for providers to get enrolled into Medicare's billing processes. And we've provided a link to this fact sheet from CMS at the bottom of this slide. And then lastly, the Medicare coinsurance and deductible would generally apply to these services. However, the HHS Office of the Inspector General is providing flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits that are paid by federal healthcare programs. Back to you, Tim.
Awesome. So a lot has changed. The traditional barriers to the adoption of telehealth have largely been eliminated. Let's talk about what other billing limitations have changed. Starting kind of at a high level, let's review the common billing scenarios that we've seen across customer base.
Okay, sure. So under the emergency period, the billing process has essentially remained the same in that there are no new modifiers for professional fee billing. This is under Medicare. So professional fee claims should continue to be submitted to the MAC where the provider is located at the time of the service and using the place of service code 02 for telehealth. And for facility fee, originating site facility fee claims, those should be sent to the MAC where the patient is receiving their services using HCPCS code Q3014. And over the last few days, Medicare has released several helpful resources, including a toolkit and a fact sheet to help providers navigate these changes. And you can find these links also at the bottom of this slide.
So you've been talking specifically about that first category on your earlier slide, Medicare telehealth. There were the other four categories: virtual check-ins, e-visits, provider-to-provider visits, remote patient monitoring. Has anything changed with respect to those?
No, there has not been any changes to reimbursement for these other types of categories that we talked about earlier. And I do want to mention that virtual check-ins and e-visits may also be offered as services to established patients in the home or in any other setting, and RPM as well, because these services are not restricted by geography or setting of care. And I'm trying to, oh, there we go. It's having a little trouble with the advancing the slides.
So let's take a close look at this slide 9 here. Can you walk us through, really, these are the codes, the main billing opportunities that could be used during this emergency period for regular care and for COVID-related visits. Sharing information that you think is appropriate here regarding these and their payment rates.
You bet. So let's start with a new patient visit. And this could be a scheduled visit or an on-demand telehealth visit in the patient's home or in an outpatient setting. And in this scenario, Medicare reimburses for live video regular telehealth visits across a wide range of primary care, specialty care, wellness, telebehavioral health, and a number of other services that are on this list of 100 plus services. Medicare also reimburses for COVID-related visits, such as in-home assessments to determine appropriate care. For these scenarios, the outpatient billing codes 99201 through 99205 would be used. If a new patient goes to the hospital ED or is admitted to inpatient and receives a consultation from a remote specialist, this might be like for a situation where a patient is receiving a telestroke visit, the provider bills the G codes. These are the G4025 through G4027 codes. Or if it's a critical care visit, then code G0508 would be used. Similarly, for a visit into the home or outpatient setting with an established patient, the provider uses codes 99211 through 99215. Again, this set of telehealth codes may be used for follow-up COVID-19 or non-COVID-19 services across the broad range of care from primary care to specialty care. And in addition to the telehealth visits from home, established patients again can initiate the brief check-ins and the e-visits. For the check-ins, the provider would bill HCPCS code G2012 for a quick synchronous or live video or phone visit, and they would use G2010 for a store and forward visit with an image or file sent by the enrollee to the provider. For e-visits, the codes are 99421 through 99423 for physicians, or G2061 through G2063 for non-physicians. For remote patient monitoring, providers use the professional fee codes 99091 and 99457, 99458, whereas 99453 and 54 are the codes that are used for the technical components of remote patient monitoring. For these services that are non-telehealth, remember they're not defined the same as telehealth, the place of service is not O2. So you would not use the place of service O2, which is only used for telehealth. And lastly then, for emergency department or inpatient follow-up visits for this category, providers would use the HCPCS codes G0406 to 408, or for critical care, it's the G0509. Again, these are for follow-ups. And then the last category is just to refresh on the payments for originating sites. These are, again, to be billed with code Q3014. And CMS will only pay for originating sites that meet the original definition of rural, except for dialysis facilities that can be in any geography.
So you want to share what the rates look like for an average rates for Medicare?
Yes, absolutely. So here we're showing on the screen the list of these commonly used telehealth services and what their rates are for non-facility and facility billing, as well as the rates for the brief check-ins, the e-visits, and remote patient monitoring that again can all be provided to patients at home and in other locations during the COVID-19 emergency.
Great. So hopefully that maybe is a little bit in the weeds, but hopefully that gives folks a sense of what's possible today. What we thought we'd do now is walk through a few examples, really targeting things that we're seeing right now in the market, what customers are trying to do, and put the billing perspective on it. So again, as a reminder, this is about Medicare enrollees, so this isn't Medicaid or traditional commercial plans, although the commercial plans may follow a similar path. Let's go to the first scenario. So we've got a handful of scenarios here. In this first scenario, the patient is at home, they're not feeling well, and they call the hospital hotline for help. Many hospitals are setting up these COVID hotlines. The call center screens the patient, evaluates if telemedicine is possible, and schedules an online visit for a remote doctor to provide the consult. The doctor connects, performs a consultation, prescribes the test, gives instructions. So Jordana, how would this be billed?
Right, Tim. So this is an example of an outpatient telehealth visit with a new patient. And since the home is an approved site of care during the COVID emergency period, the service would be coded to the appropriate level using the outpatient visit, new patient 99201 through 99205 CPT code range. And again, you would add the place of service O2 for telehealth.
Okay, so let's follow that same patient, and let's say that same patient is contacted the next day with their results. Our doctor performs another video consult, shares the results, perhaps the results are negative, and gives the patient some instruction. How would this be billed?
Right, so similar to the previous scenario, this again is a regular outpatient telehealth visit to the home, an approved originating site under the circumstances. However, since it's a follow-up visit, now it's an established patient visit. And so you would use the outpatient visit established 99211 through 99215 series, again adding the place of service O2 for telehealth.
So I think in both of these cases, the average, and of course, every market is going to be different, but the average Medicare payment is around $110 or something like that, $109, $110.
Right.
So let's go to a third scenario, and in many cases, patients are going to call their own doctor's office or their, the physician group that they're typically treated by. So let's say this patient reaches out to their doctor's office, they're not feeling well, and assuming that our doctor is trained in telehealth, the patient is web enabled, and a consult occurs over telehealth. How would this scenario be different from a billing perspective?
Okay, well, it's really pretty much the same here because it's an outpatient telehealth encounter with an established patient. It's into the home, but the home is an approved site of care. So you would use the established visit 99211 through 99215 series. And again, because it's telehealth, you would use the place of service O2.
Okay, so established patient, let's say this established patient tests positively, the provider delivers a consult to deliver the news and provide instruction. So kind of continuing this story, where do we bill here?
Right here, again, we would use the established patient outpatient visit codes, the 99211 through the 99215 series, with the place of service O2 for telehealth.
And assuming that the doctor has subsequent follow-up visits with this patient, how would those be billed the same way? Is that right?
That's right, they would be, yep.
Okay, so let's go to the next scenario. scenario 5, and just talk. So the point here is that it doesn't have to be about the coronavirus. So this, in this scenario, there's a diabetic patient who has a scheduled doctor visit, but they're worried about going to the doctor's office. They don't want to go and get sick and hang around all those sick people at the doctor's office. So they call their doctor's office, get help. The staff can qualify them as eligible for a telehealth consultation. They have access to web technologies, and the doctor performs a regular non-COVID, diabetes evaluation with their patient at home. How would that be managed?
Right. So as you said, this is just a routine scheduled doctor visit related to the enrollee with diabetes. It's not COVID-19, but there's reimbursement for any type of condition during the emergency, non-COVID as well. So the enrollee in this scenario, as you said, avoids going to the doctor's office and risking exposure. So here, it's the same billing parameters. It's an outpatient established patient visit, and it would be through the codes 99211 through 99215 series with the place of service 02 for telehealth.
Perfect. Okay, so let's switch gears now, go to scenario 6, and let's talk about some hospital-based scenarios. So our Medicare patient doesn't get on the phone. They just get in their car and go to the ED with flu-like symptoms. The ED is very busy. Perhaps some of the staff have even been quarantined and are not able to work in the ED. So the patient is taken to an exam room. A remote doctor is assigned. They log in, evaluate the patient via some telemedicine technology. They instruct the ED staff to perform the test, and the patient is sent home. Let's assume this consult takes about 30 minutes. How would this be built?
Okay, sure. So in this scenario, the telehealth consultation is coded using the ED or initial inpatient teleconsultation code. And this is series G0425 through G0427. And I'd like to point out here that these consultation codes are not specific to a specialty, and so they can be used and billed by any specialist. So it can be a psychiatrist, an oncologist, or any kind of specialist who's performing this kind of remote consultation would use this particular code. And again, since it's telehealth, it's live video, telehealth, it would be a place of service 02.
Okay. So now this patient goes home, and the next day they're experiencing some respiratory issues. They're afraid. They reach out to the hospital hotline, but it turns out that they don't have web access, so they can't perform a telehealth consult, but they can have a telephonic visit. Can anything be done here?
Yes, there can be billing here as well. So as you said, here's a scenario where the patient doesn't have the ability for live video, so they don't have a smartphone or they don't have web access. But since it's a patient-initiated visit, it's an established patient, it's a follow-up visit, the phone is an acceptable modality. And so this would be one of those brief virtual check-in visits using code G2012. And in this scenario, it's not telehealth, so the place of service 02 is not used in this scenario.
Okay. So one last one. We've kind of done quite a few here, so we'll just keep it to one more. Now we're inpatient. So this patient has been admitted to the hospital. They're placed in isolation, and to avoid unnecessary contamination, the patient room is equipped with some telemedicine equipment, and the hospitalist asks for a pulmonology consultation. Pulmonologist logs in to the telemedicine equipment and evaluates the patient. How would this be managed?
Right. So this is an initial inpatient visit. And so the telehealth consultation code would be used once again. And so this is the G0425 through G0427 series. And because it's a live video consultation, it's telehealth. And so the place of service O2 would be used for this particular claim.
And let me ask you a follow-on question there, Jordana. Does it matter where the pulmonologist is located? If they were right outside the door or at home or at a different hospital, would it make any difference?
No, it would not, Tim. There are no restrictions on where the distant site provider can be located to deliver a telehealth service.
Okay. All right. So hopefully those scenarios help flesh out a little bit both what customers are doing today and looking at doing, as well as how they might bill for it. Let's move on and change topics for a minute. We'll hit a few more slides and a shout out to our coding friends that checked our work on these examples. So we made sure we gave you good information. So let's talk about COVID-related changes, if any, with respect to Medicare Advantage plans. Has anything gone on there?
Right. So by way of a little bit of background on Medicare Advantage plans, starting on January the 1st, MA plans have had the flexibility to offer additional Medicare Part B services via telehealth. And this is in any geographic area and from a variety of places, including from the patient's home. And they are able to do this, add these extra benefits as basic benefits rather than as supplemental benefits. So now, in response to COVID-19, CMS has announced that they will exercise enforcement discretion and allow an MA plan who did not include these additional telehealth services in their 2020 plan bid to be able to provide these services via telehealth during the emergency period. In addition, plans may now waive or reduce the cost sharing for services, including for telehealth.
Great. So let's talk about prescribing now. So remote prescribing has been an issue for telehealth. We haven't been able to use telehealth to prescribe controlled substances, for example, without an initial in-person visit. Has anything changed on this front?
Yes, during the public emergency, there is now an exception that allows DEA registered prescribers to issue prescriptions for controlled substances using telemedicine without a prior in-person evaluation if the prescription is for legitimate medical purposes, it's a real-time two-way audio-video encounter, and the practitioner is acting in accordance with the state laws.
Okay, let's cover one more topic here. Let's talk about cross-state licensure. Historically, this has been a huge barrier to telehealth. What's been happening on this front? Has there been any changes as a result of the emergency?
There have been some changes, Tim. We're seeing both federal and state officials addressing licensure requirements to encourage care from a distance. HHS has implemented the 1135 waivers, which authorized CMS to waive the Medicare requirement that a provider must be licensed in the state in which he or she is practicing, if the provider has a license from another state, and if the provider is enrolled in the Medicare program. Now, this only applies to providers who are servicing beneficiaries in federal healthcare programs. So it's important to be aware that the licensure waivers that are granted by CMS do not waive state or local licensure requirements. Therefore, in order for the provider to avail him or herself of the federal waiver, the state also would have to waive its licensure requirement for the type of practice for which the practitioner's licensed in his or her home state. So far, there's been about nine states that have invoked these healthcare licensure waivers in their emergency declarations. And as of just a few days ago, these states include Arizona, California, Florida, Mississippi, North Carolina, Oregon, Tennessee, Texas, and Washington. And again, even in states where the waivers have been implemented, providers need to read the fine print because the waivers may have certain limitations. And our listeners can find an up-to-date listing of these states and what's happening around these licensure waivers on the Federation of State Medical Boards website. And we have the link here at the bottom of this slide.
So just to reiterate, thanks, Jordana, on that. Our friends at Teladoc have shared with us that there is a lot of fine print. So it's important to read carefully what has been placed in these emergency declarations and before we jump and assume that cross-state licensing is available. So finally, our focus in this webinar has been on Medicare reimbursement. However, can you give us a glimpse at what else besides licensure waivers is happening at the state level with respect to COVID-19 and telehealth?
You bet. We're seeing many states taking action to expand telehealth services during the pandemic. By way of example, New York State's Health Department recently approved reimbursement for telephone-based evaluation and management services for Medicaid patients. And in California, under their state's Emergency Services Act, all Medicaid, Medi-Cal managed care health plans must now allow members to use telehealth, and Medi-Cal plans must reimburse providers for telehealth services at the same rate as in-person visits. On the commercial side, we're also seeing plans expanding telehealth coverage and reimbursement, and we're seeing some plans implementing policies that pay the same rate as in-person care. We're seeing others removing copays, and some are even offering telehealth services for free. And with this rapidly changing policy landscape at both the federal and the state levels, I want to mention that there are a number of great places to go for resources. One can look on the Center for Connected Health Policies website. They put together a billing guide. They have several fact sheets to help understand the different policies and what's happening at the state level as well as the federal level. The ATA's website has a number of very helpful resources. And then CMS.gov has put out a number of fact sheets. There's a new provider toolkit and other resources. And you can sign up for CMS announcements, which I find to be very helpful to help stay on the pulse of what's happening. And of course, we're here as a resource for any questions that may come up at any time.
Okay, well, that kind of concludes the material that we've prepared. As we're reviewing the questions that have come in here, I'd like to extend an invitation to all of you to learn about the solutions we've been working on to help you respond and treat COVID-19. You can find that information at intouchhealth.com. And we're starting to get questions here, so let me jump in. So let me ask the first question. If a patient who isn't feeling well and suspects COVID exposure calls 911, can the EMS personnel do a telehealth consult with an ED doctor? Jordana, you want to take a stab?
Yeah, you bet. Yeah, yes, they can. And here's another great example of how telehealth can be used to keep someone at home and avoid going to the emergency department or a hospitalization. So in this scenario, the EMS personnel could take the vitals and initiate the live video visit with the ED doc. Um, in this scenario, I would suggest, again, using the outpatient new patient code set, which is 99201 to 99205. And again, use the place of service O2 for telehealth.
Okay, so here's another question. So a physician would like to start providing telehealth services to Medicare patients from my home. Is this allowed?
Great question. Yes, there are no payment restrictions placed on providers who are delivering Medicare services from home. Practitioners can add their home addresses to their Medicare enrollment file by reaching out to their MAC, and this they can do through the new MAC hotlines that have been set up by CMS. And then if the practitioner reassigns their benefits to a clinic or a group practice, the group practice then would be required to update their Medicare enrollment with the individual's home location. So there are various ways to do this, but yes, the distance site provider can be located anywhere. There are no restrictions on that that area.
Okay, there's been a couple of questions here, essentially asking, will these policy changes be permanent, or do you think they'll be flipped back after the emergency?
Wow.
Do you have a crystal ball on that, Jordana?
I know. I wish I had a crystal ball, right? Well, I think that telehealth will continue to play a really vital role during the coronavirus crisis. And this time period gives an opportunity for telehealth to really demonstrate its incredible value. And I think during this time, it will become a regular part of the healthcare delivery system. So I'm hoping that when the crisis finally comes to an end, and I hope that is soon, the new reimbursement policies will become permanent. It seems to me that the paradigm has changed, and I don't know about you, Tim, but I can't imagine ever going back to the way things were.
Well, that's certainly what we'd like to see happen. But you know,
Yeah.
personally, I think we're in this for a while. So
Yeah.
the longer we spend becoming more digital in healthcare, the harder it will be to reverse those trends. But I don't think we know for sure. Right. I have another message here. Another question: would Medicare Advantage follow the CMS Medicare guideline? Can you speak to that?
Right. So Medicare Advantage, well, let me back up. The telehealth waiver addresses Medicare fee-for-service. Okay, and the guidance that we've seen so far, and Medicare Advantage is not fee-for-service. The guidance that we've seen so far from CMS around MA plans speaks to the fact that the plans that didn't have telehealth or additional telehealth that goes beyond the basic benefits in fee-for-service, when they didn't have those benefits in their plans in their 2020 bids, that they could still add them now during the crisis. So that is a good question. I feel like I'm going to need to research that a bit because the fee-for-service environment has now changed. Now we don't have the restrictions that we had. And whether or not that translates into Medicare Advantage having to follow those exact rules, although now they have flexibility, they're not tied to urban locations, or to rural locations rather, they're not tied to settings. I'm not sure if there's any difference that would be applied to them at this point, but that's something that we can research. I haven't seen anything come out beyond just indicating that the plans that didn't have them in their bids so far would be able to add telehealth to their discretion. So let me do a little research on that one. Great question.
Okay. Another question, are there any special codes that should be used for COVID-19 screening using telehealth?
No, there are no special codes for COVID. The codes that are on the list, again, the list of 100 plus codes, this is telehealth, apply to COVID related visits as well as non-COVID, just regular healthcare visits. So, you would just use the regular outpatient E&M codes unless the patient is in the emergency department or the hospital. And in that case, then you would, for an initial visit, you would use the G0425 through the 27 codes.
Okay. I think this is an easy one. Did you say CMS requires the provider to be licensed in the state where they are located?
Yes.
I don't think
Yes, see, that is the case. And where the waiver comes in is that CMS has waived the requirement for the provider to be also licensed in the state where the patient is receiving services through telehealth. So as long as they have that valid license in their state where they're located, and it's for comparable services, then that one, and it's a federal program, federal provider, then the one license would apply. But again, one has to follow the state rules where the practice is occurring with the patient.
Okay, so just a follow-up question on that. So if I go to Florida and I'm not licensed in Florida, but I want to provide telemedicine services back into, New York where I'm from, am I not allowed to do that?
So say that again, Tim. Sorry.
Well, I'm just following up on this line of questioning. So if you're on vacation in Florida and you want to see your patients back in New York, but you're not licensed in Florida, but your patients are in New York where you are licensed.
Right.
Does CMS require that I have a Florida license to be able to provide that service? I'm asking you because I don't know.
Well, let's see. So the providers in Florida, but they're
they're not licensed in Florida.
Right. So I think there would be an issue there. That's a good question.
Just because of the way CMS has created these waivers, is that because normally that would not be an issue.
That's right.
Okay. Well, we can get final clarity on that. Yeah. Another question: are virtual check-ins only billable if initiated by the patient?
That is correct. By the rules around the virtual check-ins is that they must be patient initiated, and that patient must be an established patient. So yes, it would have to be patient initiated in order for that to be separately billable. And again, there's some requirements around those virtual check-in codes that people should be aware of. Again, they can't be billed if it's related to a A&M visit that was in the previous 7 days, next 24 hours, or soonest available appointment.
Yeah. Okay. Another question, this is about federally qualified healthcare facilities and RHCs. Can they bill as a provider of telehealth services for Medicare beneficiaries?
Right. So unfortunately, right now, they still cannot bill as a provider, as a distance site provider. The waiver did not change that existing policy. The legislation didn't change it either. I have seen that there is that making the FQHCs and RHCs as a distance site provider is something that Congress is considering. It's one of the provisions in the Connect for Health Act. And so we may see that change coming about. But so right now, FQHCs and RHCs can only serve as originating sites. But what they can do is they are able to bill separately for virtual check-ins. So again, for the virtual check-ins, the synchronous and the asynchronous check-ins, and they would use code G0071 for both of those services. So hopefully we'll see that particular policy barrier changing in the near future, and so that FQHCs and RHCs can also be providers of services during the crisis.
Okay, so that's been a long-standing telehealth issue.
That's right.
Okay, so another question. I'm a physician who would like to provide telehealth services to my Medicare beneficiaries in their home during the COVID-19 emergency period. Will I get paid the facility or non-facility payment rate?
Okay. Well, this is something new with the home being an approved site of care, with a few exceptions that we had recently for substance use disorder treatments and end-stage renal disease. So it's not something that I've seen guidance come out on yet from Medicare, but if the provider is part of an institution, then it will likely be the facility rate. But if the provider is part of a separate practice and is not hospital-based, then it will likely be the non-facility rate. But I think we're going to have to wait and see a little bit on that, and maybe Medicare will be issuing some guidance and more information around that to help clarify that particular point.
Okay, we're getting a lot of technical questions here. So, okay, this has to do with texting. So, how many times are you allowed to bill for texting visit for a texting visit with a patient? What if they text 3 or 4 days in a row? So this, I guess, would be a patient-initiated text. Is there any limitations to the frequency of the? I think I've read this, but I don't know the answer off the top of my head. Do you happen to remember?
No, I haven't seen anything about frequency limitations or texting in particular. So that's one that we'll take a look at and get back to the person with the question with a response.
Okay, I'll do this one last question. I think we're going to be out of time. Can residents bill for telehealth?
Wow.
Do you know if residents are allowed to do this?
Yeah, I think there are some restrictions on residents. So that's another really good question. I know we need to expand the workforce right now. So I think there's supervision points there regarding residents, and that's a good question. So let me work on that research and get back to that person as well.
So I think we're out of time. There are a ton more questions here. Jordana, I think we'll be happy. I'm offering you up to respond to folks who've got additional questions. We'll get to those. Maybe at this point, we'll bring this to a close. I'll turn it back over to Scott.
Great, thank you, Tim and Jordana. So I'd like to reiterate that this webinar has been recorded, and we will be sending a recording out to all attendees, as well as have it available on the website. Also, I'd like to say thank you so much for your participation in the Q&A, and for all the questions we were unable to get to, we will try to follow with each of you offline individually. And then lastly, just a big thank you for our presenters for today's presentation. And then if there's any additional information, I'd encourage you to please visit our website at intouchhealth.com or just email us at feedback@intouchhealth.com or any of the contact information available on the slides. Thank you, everybody.
Thanks a lot.